Well, good morning or good afternoon to those of you who are just coming in from the Zoom waiting room. We're going to give folks just a couple more minutes to join us, or a couple more seconds, I should say. Excellent. Well, welcome everyone. My name is Joy Burkhardt, and I'm the founder and executive director of 2020 Mom. Our mission is to close gaps in maternal mental health care. We're thrilled that all of you are joining us today. There are over 700 of you who have registered, and we welcome those of you joining us live and those of you who are watching the recording, and those of you who are watching the recording on our YouTube channel retrospectively. Welcome to all of you. We're thrilled to be welcoming two experts and guests in the field of ACEs, Adverse Childhood Experiences, to tell you more about the latest in the field of ACEs. Welcome with me today is Dr. Jonathan Goldfinger. He's a pediatrician. He's currently the Chief Executive Officer at D.D. Hirsch Mental Health Services. We invite you to check out his bio and learn more about the work that D.D. Hirsch is doing that's so critically important and longstanding here in Southern California. Dr. Goldfinger has done some remarkable work working with the Surgeon General in California, Nadine Burke-Harris, as an advisor, and also with her previous nonprofit organization located in the Bay Area, the Center for Youth Wellness. Also has done some critical work at 0 to 3, the nonprofit that so many of us in this space know. Welcome, Dr. Goldfinger. I also want to introduce our second guest, Amanda Wynn, who is a licensed social worker doing macro level work, which I love, and you'll get to see and get a taste for her work here in the presentation today. She served as the national director of a resource center supporting families and children at UC Berkeley, and she'll tell us a little bit more about her work there, and currently serves as the West Coast manager of the HOPE program, which you'll learn about here. It's the P that has been added to ACEs around positive experiences. You'll get to learn more about that out of Tufts University and Medical Center. Welcome to both of you. And again, we invite you all to take a look at their backgrounds and their work on their websites here. Throughout today's session, our team will be moderating the chat and also be sharing some resources that you hear about during the session for you to copy and paste or open up as we present. With that, I have the great pleasure of turning things over to an advisory board member who I just introduced, Dr. Jonathan Goldfinger. We're so pleased to have you with us today, Dr. Goldfinger. Thank you.
Thank you, Joy. Excuse me, and thank you everyone for joining us. This is a really exciting time for me as a researcher who's focused on intergenerational trauma throughout my career and what we might do to address it, to prevent the intergenerational cycles of trauma. And I'm excited for us to talk about that briefly today. Ultimately, I think the goal that we would all share is to ensure that when we are thinking about ACEs, we're not just thinking about the individual, the child, the adult, the family, we're thinking about the generations involved. And this is kind of going to be a high level, here's how, with some practical movement in this space you'll learn about. So the reason we're gathered here is because childhood trauma, or the flip side of it, the experience itself, known as adverse childhood experiences, can look like this. It can also look like this, maybe a few years later. Child may be beginning to get a little more obstinate. It can look like this as it materializes in domestic or partner violence. And the child kind of experiences it secondhand, but still quite viscerally. It can also look like this. And I know we all know that this is a form of trauma, but it behooves us to think about the impacts of systemic racism, and I'll talk a little bit about that later, even within healthcare and how we can address it. Or it can look like this. This is intergenerational trauma. This is actually my trauma as the child of the children of Holocaust survivors. I experienced ACEs from birth because what happened in Nazi Germany was transmitted through the DNA of my parents as well as their behaviors. And when we see things like this, which unfortunately in the rise of anti-Semitism today in America, these are triggers for me, for my family, for my wife, my children. And so intergenerational trauma is this ongoing interaction between our generations, our history, our experience, our environment, how we're treated, and our DNA. Many of you probably, hopefully already know the ACEs of the original study from CDC and Kaiser Permanente. What you may not know is what we're talking about today, that arguably the first ACE has to do with the mental health of the parent. We'll talk about that a bit later. But what you can see here are the prevalence of specifically the ACEs in one of the most recent research studies, late 2020, that showed significantly, they put together abuse and neglect, physical and emotional, but emotional abuse or neglect, maltreatment that was emotional, interestingly, is the most prevalent ACE. Maternal mental illness appears to be one of the first, and interestingly, maternal mental illness is tied to emotional neglect, as you saw with that mother. She's depressed. She's not looking at the baby. I used to lead a breastfeeding medicine center in Los Angeles, and my staff would say, Dr. Goldfinger, why isn't she latching the baby? And she'd be looking away. And so these are inextricably linked. So when we talk about maternal mental health as the first ACE, it's important to recognize its connections to all the other ACEs, perhaps the origins of many of the other ACEs, as well as some other factors that come along frequently with it: substance use and domestic violence, let alone a more common ACE, divorce. It's also important to understand that ACEs have significant disparities in terms of the dose. How much trauma does any child experience? Significantly, if they're Black or Latinx, it will be higher than if they were white, but even more prevalent and more concerning if they're low income. So poverty leads to higher trauma, higher adversity, which then leads to further mental health challenges and poverty. And this is part of the never-ending cycle we're here to prevent. What's also interesting is in studies where parents are asked about their own child's adversity, what you can see is they kind of downplay it. So parents are a critical piece in erasing the stigma of ACEs, including mental illness, to make sure that they're more comfortable of it, because when adults are asked, two modern studies here, you see a significant difference. And what's even more interesting to me as a researcher in this is the greater disparity between what parents say their children experienced and what they experienced for substance use and domestic violence compared to mental illness. At D.D. Hirsch, we've worked hard to erase the stigma of mental illness. This is an indication that there actually is greater stigma in substance use and domestic violence. So when we talk about first ACEs, if these are some of the three, and they often cluster together, we've got to be looking for them together, and we've got to erase stigma of domestic violence and substance use alongside that of mental illness. Hopefully you already know this, but the data is inextricably clear that almost all, if not all, leading causes of death in the United States are driven by our childhood adversity. And what I now research and look at closely with D.D. Hirsch, which is home to the nation's first and most comprehensive suicide prevention center, is this significant difference between the physical health outcomes of adversity and the behavioral health outcomes of adversity. And suicide being a leading cause of death in America, and the second leading cause of death in teens and young adults, is one we're looking at. How do we actually predict it? What you see here is the trauma America experienced, in the last year and change. That trauma manifested as mental health challenges. What's also notable is the younger generations, if you will, think of the 18 to 29 as the earlier life parents, and then the 30 to 39 as the later parents who got started later, like me and my family. Those still have significant differences in terms of the manifestations of trauma with mental illness. They also have significant differences in access to care. So again, these younger generations not only suffer more greatly from trauma and its mental health impacts, these parents are also less likely to have care. And it also depends on the color of your skin. As you see here, interestingly, trauma research, ACEs research, and mental health research have all found that multi-ethnic, multi-biracial kids and adults experience higher doses of trauma than even one minority group or the white privileged class. And so it really is important as we think about the politics and the clinical care and rooting out systemic racism and inequity in our care and our financing of mental health care as well, that we think about this kind of more modern melting pot American, that child, that young adult. In our work at DD Hirsch, where we focus on crisis care, we know that there are these inequities day in and day out. We're 24/7 on the mental health crisis and suicide prevention line, soon to be a 988 number near you. And we know that substance use, suicide, overdose, mental illness are all higher in young people, BIPOC, and LGBTQ communities, but down in older, white, straight populations. 42% of the calls to our lifelines are young people. Interestingly, when we looked in LA, it was a tale of the richest and the poorest having the highest rates. So trauma knows no socioeconomic bounds. Even if there's a higher burden in lower income children, it still significantly affects higher income families, and we can't forget about them. In fact, I view it as an opportunity to think about where we can fundraise for the issue in its entirety and have greater unity around intergenerational trauma. And there are disparities, again, in the experience of suicide and mental health crisis, particularly for African Americans in the Southern California region. And I point out that even as we look at this, there's even disparities in our data. As a public health professional and researcher, this is unacceptable. Nearly a third of calls and data missing the race ethnicity we can't solve for if we don't understand it. Dr. Burke Harris and many others have been working on adverse childhood experiences, research and innovation for years. Here's one example of the data. These are some of the outcomes associated with it. This is some of the research. You can look it up online with the slides. And in California, we learned this costs us tens of billions of dollars in excess healthcare spending and disability adjusted life years. At DD Hirsch, we kind of look at this in terms of the inseparable connection between the mind and body. We believe if we understand intergenerational trauma, we can one day ensure everyone has access to the care that addresses it. And my area of focus with, I'd say, leverage with a lot of people invested, like 2020 Mom, is the birth to childbirth life course, or the reproductive life course. If you don't believe me that this is a cycle that is addressable, if we address first ACEs, here's some research out of one of the large coordinated care, partially insurer, partially care manager, called Health Share of Oregon, where they looked at the members with the costly, most complex health conditions as adults, and they found a frequent sequential cascade of adversity. And it started with parents early, struggling with poverty, where we saw greater adversity, and it translated into greater food, housing insecurity, ACEs in the kids. And you can read on and on the mental health, behavioral health, physical health challenges, educational access challenges, involvement with the criminal justice system, overall poor health and well-being that then translated back when they were parents, including in unwanted pregnancies. And this is kind of how it looks throughout the life course. To solve for this, though, I've been looking at healthcare and thinking, well, how do you address something intergenerational? I'm a pediatrician, there's an OB, there's a family doc maybe who knows more than both of us about how this unfurls. We really start to understand the problem. The problem is that healthcare is fragmented and it doesn't follow us throughout life or the life course. So we have to kind of put the pieces together. And when we do it, we have to think of our initiatives, even if we're thinking of the perinatal period like 2020 Mom, what's the upstream piece that might be missing in our research or our advocacy that would have a preventive effect on that cascading risk? Then we have to measure downstream as well, not just what's happening in our area, which clearly is helpful and costly to, has costs avoidable that we can improve upon and get paid for, but what's even further down the line and who are the payers to pay for it? And then all this has to be coordinated and analyzed. So for example, from the start of life, you have Black mothers and babies who we all sadly know die at a higher rate than white mothers and babies. And we're talking about lifelong exposure to racism, according to public health research, being the cause, but not just in healthcare, in every other health and human service as well. But when we look at the initiatives focused on this, and I've been kind of studying these and advising a number of them for years, you have people focused on preterm birth, let's say, that's the outcome. Maternal mental health, that's the issue. That's also an outcome of ACEs. But we're not always looking earlier in the life course. What happened preconception to that mother, right? What were the behavioral health challenges preconception? And interestingly, the evolution of maternal mental health disorders in America, or what people call perinatal mood and anxiety disorders, has increasingly gone upfield through leadership at the American College of Gynecology, Obstetrics and Gynecology, and others. And we have to do that. We have to go upfield and say, what happened preconception? What happened prenatally? And how is it translating postpartum? And then what are we measuring downstream? Is it just about, okay, did this mother get care? Or is it about what we're talking about today, preventing and mitigating the transmission of ACEs? Is that baby, if we address the issues of the mother, thriving? So just to give an overview for those who don't know what the maternal mental health disorders, these are some of the most common. Depression being something very much tied to the prenatal or postpartum period. Dyspnea being something that's prolonged over the course of years, that's then manifesting as depression-like symptoms. Classical generalized anxiety related to prenatal or postpartum hormones and other challenges. OCD, the trauma of birth, which is extremely prevalent, and PTSD. And as I stated, these things didn't start as soon as the mother gave birth. Interestingly, when you look in almost every study, there was something there prenatally and often something there preconception. So as a pediatrician, I think about the life course, what's happening with the teens? Well, we know that teens, due to ACEs and trauma, are significantly using substances, alcohol. There was a study by the American Psychological Association in young adults saying parents were the demographic in America during the pandemic who increased drinking the most. They didn't just start there. There were once upon a time young teens suffering from trauma, and the pandemic was the trigger of that trauma. And alcohol from ACEs, alcohol use to kind of, if you will, soothe the trauma of ACEs, leads to all the causes of death. Motor vehicle accidents are the number one in kids, but it's pretty much driven by drunk driving or even distracted driving. Homicide, suicide. So this is why all major experts in this field recommend screening universally for teens, young adults, new parents, prenatally, postpartum, for substance use as well as mental health. And interestingly, in the substance use ACE, which is another one of the first ACEs, if you recall, we know that a very small intervention in primary care and prenatal and postpartum care can actually have a significant impact. Even more interesting for me as a researcher is the research showing preconception ACEs, if you will. We may need a new term for them since that child's not even conceived, has an effect on the baby. So look at this study showing that when the teens were drinking, whether father or mother, higher impact dose response with the father. If they conceived a baby, that baby was significantly more likely to be born with heart disease. Again, a study like that looks at it, but doesn't go even farther upstream and think about what were the ACEs involved. Was it the ACEs of the child who became the teen who drank, who became the mother, that led to that baby's heart disease? Or was it the actual drinking? And that's what we have to start to study across generations, how I believe this will all unfold. Clinically, we've taken the data and the significant impact of ACEs and toxic stress in California. We've pulled it all together for you. If you want the information, go to acesaware.org. We have it for adults, for caregivers of children, providers who work with children, providers who work with adults, payers. There's all sorts of amazing training on there. It's free, acesaware.org, through the state of California, in the leadership of our Medi-Cal agency, as well as the California Office of the Surgeon General. And for me, the take home, hopefully for you today, is with all of this high risk, this is not destiny. I'm here as the CEO of one of the largest and oldest mental health and suicide prevention organizations leading the nation. And I had the first ACEs. If we have a life course care approach, we can significantly avoid these things. This is kind of what it would look like in practice. We know through research of some folks connected to the HOPE work you'll hear about briefly soon, that children whose mothers are in good or excellent health, including mental health, won't experience ACEs. Certainly maternal mental health has consistently been tied to child maltreatment. So we need to really think about the life course of mental health, substance use, and IPV. I would add those to the first ACEs list because they're clustered together. How do we address all three of those for children, teens, young adults, and new parents? Obviously, we want to prevent teen pregnancy because it's tied to those three. We need to think about home visiting, dyadic care, pregnancy through infancy to address the mental health of mothers and fathers and other caregivers. We need to think about parenting education as a preventive measure, high quality, affordable childcare, and financial insecurity or support for low income families. This is the bundle if you're a payer. This is the bundle of services that you've got to pay for equitably and with parity, because if you get this, I guarantee you, your next generation of members are going to be healthier. This is what we've been doing at D.D. Hirsch for 80 years now. We have one of the nation's first places where mothers recover from mental health, substance use, domestic violence, and get job training, financial well-being, and we keep kids out of the foster system. And we do that first ACEs work and ensure generations thrive. Briefly, I wanted to share with you what was shared with me, and we can give you the slides. There's major changes in California driving this. There's something called CalAIM, where we're moving toward a more universal payment system for mental and physical health. And in this change to what are the criteria for care, we're now including ACEs childhood trauma, we're including dyadic models, and we're thinking of substance use as how can it be part of mental health care. There's congressional bills I won't go through, but you can take a look at them that we track at D.D. Hirsch, and a lot of them are about mental health equity for youth and people of color. And from my standpoint, those are the ones that are really going to ensure we can address the first ACEs. And here's just a surprise. In California, our governor put forth a bill, a budget we believe will mostly go through $4 billion for youth mental health, and includes $200 million a year to focus on the dyadic integrated care models that serve mother and baby at the same time. And I'll leave you with a story. At D.D. Hirsch, we're on these crisis lines 24/7. We just started with 911 transferring calls to us the other day, and a mother with schizophrenia called us all about her own journey, struggling with stigma, discrimination, finally able to try to get her to get care for her, get her meds, get her therapy. She couldn't access it. She was hopeless, sad, and we were able to get her to support groups, saved her life. But the lesson that she took home from it was she'd like us to support her son. This is true of all parents. This is how we feel. This is how we think. This is how I think as a parent. This is what I've seen throughout my career as a pediatrician. So when we address the first ACEs, we don't have to get this far in the life course where there's a 20-year-old kid. We can start with the baby, and we can guarantee that child and that mother and that family are safe and thriving. And with that, I'll turn it over to
Jonathan. Thank you so much for your presentation, and that story about Lauren, I think, really drove it home for me, and maybe some of you too, and particularly that she's grateful for her care, but she really wants you to support her child too. And don't we all have that as mothers and parents, fathers, Jonathan, that in common, that we are mama bears when that baby comes and we can finally kind of catch our breath. We want our children to have better lives than us and be well cared for. Well, thank you so much, Dr. Goldfinger. We'll have time at the end of our presentations to talk to Jonathan and Dr. Goldfinger, Dr. Goldfinger a bit more with some Q&A in just a moment. But we wanted to follow up Dr. Goldfinger's presentation with just a quick overview that I'm going to give. We'll be inviting the person who created this framework, the Adverse Babyhood Experience framework, to a follow-up discussion after today's session for a deeper dive conversation about these 10 categories of what she frames as adverse babyhood experiences. And specifically, she has called up the fact that it makes sense to highlight that preconception, as Dr. Goldfinger shared, during pregnancy and the first 3 years of life are particularly important. And many of us in this field, of course, know that. And the work of organizations like 0 to 3 have been highlighting that for quite some time. And she's really bubbled up, here's some factors and things we should be thinking about in terms of adverse babyhood experiences. Again, the time frame is here. So negative experiences that happen before people conceive, women conceive, for parents, in particular mothers, and of course, pregnancy through conception and the third birthday. Why do they matter? These things, when you look through the 10 categories, largely we can do something about these things, as Dr. Goldfinger is really trying to emphasize as well through policy change and otherwise. You'll see the same types of things that were highlighted in Dr. Goldfinger's presentation about ACEs in general, chronic illness, lifetime of mental health conditions, a higher risk for when someone suffers from an ACE or an ABE, if we talk about adverse babyhood experiences. So I'm going to just talk a little bit about the 10 categories. Again, we'll have time to unpack some of these in more detail later with the person who created this framework, but I wanted to introduce them to you since I know all of us in this field have been talking about, or all of us are interested in this, and some of us have already been talking about this important framework. So maternal loss or trauma, really, it means that she has suffered from an ACE in her lifetime, essentially. That's what number 1 is about. Number 2 is maternal lack of support. So low support, loss of support, and you can use your imagination about what that means. So social support and people to lean on, practical support, ability to cope with distress. Next slide. Number 3 is maternal physical stress. It can be a factor. So think about a mother having severe anxiety or other types of illnesses can be a risk for low birth weight, a premature birth, etc. We know that depression, untreated depression and anxiety during the perinatal or during pregnancy rather is actually a leading cause of low birth weight or low preterm birth babies. Maternal emotional stress can cause be an ABE, an adverse babyhood experience. We already know that, as Dr. Goldfinger has discussed, but it's nice to see it called out specifically in number 4. Medical complications also in mothers around the time of delivery. I think those who have had near misses or complicated pregnancies will absolutely agree that this is something that should be highlighted because there's impact to her and her baby. Other complications in babies, so poor growth in utero, cord issues around the neck. You can read the additional items in number 6. Basically the APGAR score kinds of issues in number 6. Number 7, separation of baby from mother. That one seems very apparent that would cause distress in a baby. Baby's birth weight, we already hinted at this, but if there is a low birth weight, that can be considered an ABE. Breastfeeding concerns for a number of reasons. And then 10 is really just to look for early signs and symptoms because these things can be, risk can be mitigated and support can be provided. That's an overview of the ABE model. Again, we'll have a chance to talk with the creator of this framework in a follow-up session. And now I have the great pleasure to turn it over to Amanda Wynn, who will talk a little bit about the HOPE framework and the research that came out to talk about the P that's been added to ACEs, so PACEs, and where that P came from. Amanda, so excited to turn it over to you.
Yeah, thank you. I'm excited to be here. So I'm the West Coast project manager for the HOPE National Resource Center, and HOPE stands for Healthy Outcomes from Positive Experiences. We're a group based out of Tufts Medical Center in Boston, though I live in Portland, Oregon. but importantly, moved to Portland about 5 years ago after spending a decade in the Bay Area. So I was in California as Nadine Burke-Harris was doing her work, and probably Dr. Goldfinger, though didn't know him at the time, around ACEs. And it was becoming part of the culture around trauma, was looking at ACEs, screening for ACEs, noticing ACEs, talking about ACEs. There were ACEs webinars, there were in-person ACEs trainings. Providers were starting to get the sense that they should be asking their patients about their ACEs. ACEs were everywhere, especially as a social worker who was working in the parenting and resiliency and poverty space as I was. Then I got divorced. And I realized, because I was so informed about ACEs, that my divorce was giving my children an ACE score of 1. And all of a sudden, ACEs hit home in a very different way for me. And I started thinking about what it meant to have an ACE score, and if that was destiny. Did that mean, I knew that ACEs were connected to long-term poor health outcomes. Was I guaranteeing that my children were going to be at a higher likelihood of experiencing, a heart attack or asthma or substance use? And so I started to do some research about what was out there to respond to ACEs, because I needed to be part of the solution. I didn't just want to know about ACEs, and it's critical that we know about trauma in the folks that we're working with and in ourselves, but I wanted to be part of the so what. And I found Hope, led by Dr. Sege, and our mission, really grounded in science, is to build upon the formative role of positive experiences in human development. And we're hoping to inspire fundamental change in how we advance health and well-being. So we're really looking for a groundswell. We're hoping that 5 years from now, positive childhood experiences are going to be as widely known as adverse childhood experiences. And let me tell you a little bit about why that is so important. Next slide, please. So the original ACEs study, as Dr. Goldfinger mentioned, was done in the late 90s. A little bit more recently, in 2015, they did a population study and asked the behavioral risk factor surveillance study, it's a mouthful, in a population in Wisconsin, which, to note, similar to the original ACEs study, was predominantly white. So we recognize that as an issue, and we are working towards recreating this study in communities of color to make sure it's as relevant. But they asked not only about ACEs, but about positive childhood experiences as well. And they were looking at how those things correlated with mental health. Next slide. And so the questions that they asked around positive childhood experiences were these 7. And they asked adults to reflect back on their childhood. So did they feel that they were able to talk to their family about their feelings, that their family stood by them during difficult times? Did they enjoy participating in community traditions? Did they feel a sense of belonging in high school? I know I didn't. Did they feel supported by friends? Did they have at least 2 non-parent adults who took genuine interest in them? And did they feel safe and protected by adults in their home? So these were the 7 positive childhood experience questions that were asked on this survey. And what they found was pretty astonishing. So the original study was done by Christina Bethel, Jennifer Jones, and a few others. Dr. Sege was among them. And if you go to our website, positiveexperience.org, you can see this study published in JAMA Pediatrics. But what they found, next slide, was that positive childhood experiences matter and they protect adult mental health. So when you looked at folks who could answer yes to all of those questions, or at least 6 out of 7 of those questions, they were 72% less likely to report depression or poor mental health in adulthood as compared to those who could only answer yes to 0, 1, or 2 of those positive childhood experiences questions. And we see that it was dose dependent. So the more positive childhood experiences you had, the lower the likelihood that you would experience adult depression or poor mental health. That alone was exciting. But what was even more fascinating to us was, next slide, we found that that effect existed even with folks who had ACE scores of 4 and higher. So those who had 4+ ACEs, if you look at this, if they had 6 to 7 positive childhood experiences along with those adverse childhood experiences, they were about 20% likely to experience depression or poor mental health, compared to about 60% of those who only had 0, 1, or 2 positive childhood experiences. So this was big. This gave us information showing that adverse childhood experiences are part of the picture, but they're not the whole picture, and they're not a diagnosis in and of themselves. Next slide, please. So we've been working with ACEs Connection in California with the Office of the Surgeon General to talk about how critical it is that as we have providers who are screening for adverse childhood experiences, that they're also screening for positive childhood experiences, or the capacity for a family to provide positive childhood experiences, because we know that if we can pack in those positive childhood experiences, we can mitigate some of those long-term mental health outcomes associated with already existing adverse childhood experiences. We also know that these positive childhood experiences have the capacity to disrupt future adverse childhood experiences. So what we found is, generally speaking, the kinds of positive childhood experiences that seem to be the most effective in mitigating long-term mental health outcomes cluster in these 4 areas. Relationships, and this is not just with a primary caregiver. Remember, one of those questions was, did you have positive connections to 2 non-parent adults? So we've got relationships, we've got safe, equitable, stable environments, not just to live, but to play and to learn. And this includes making sure that basic needs are met, making sure that there's a safe place to play outside, making sure that school feels safe. Social and civic engagement, so ensuring that kids have a sense of belonging and connectedness, that they matter. So this can be as simple as encouraging your child to take some ownership around the house, having a job where they really get to contribute to the family. I mean, it sounds like just chores, but when you build that sense of mattering in a child, you are promoting their social and civic engagement. Obviously, as the children age, that can look different. That can look like volunteering in the community or getting involved in clubs or sports. But even at a very, very young age, families can support a child in that feeling that they matter. And then there's emotional growth through playing and interacting, largely with peers, but certainly with grown-ups too, for self-awareness and self-regulation. Next slide. Just kidding, go back one. So we know that not everybody has equal access to these 4 building blocks, right? We know that that communities of color, that LGBTQ+ communities, that low income communities have a harder time accessing some of these building blocks. So the work that we are doing at Hope National Resource Center is to train everybody we can. We're working with medical providers, with home visitors, with K-12 educators, with early childhood people, with juvenile justice. Hope is not an evidence-based model that is manualized. Hope is a framework based on the research that can be integrated into whatever you're doing. And essentially what it says is that, shocking, there's hope when there are ACEs. and that anybody who interfaces with a family has the capacity to A, screen for positive childhood experiences, screen for these building blocks, and when you find them, lift them up and celebrate them. B, provide some psychoeducation that your ACE score is not a diagnosis. It's not a guarantee, that there are things that you can be doing to offset some of that trauma that you did experience. Also really important for that psychoeducation for parents who come to parenthood with high ACE scores, to know that this is not necessarily a guarantee that their children are going to suffer the same fate, and that they have power to create positive childhood experiences. And then C, to make sure that however you're interacting with families, you are helping them connect to these building blocks. And every kind of provider, every individual can do that differently. But that's, and so as we're talking to folks, we're brainstorming with them and helping them come up with ways to promote access to those 4 building blocks. Because we know that positive childhood experiences are a really important so what to ACEs. So next slide. So we have a ton of information on our website. We have ways that home visitors and medical providers and educators and families can increase access to the 4 building blocks. Like I said, we do trainings all the time. We have videos. I'd really encourage you to check it out and have a conversation. We've also created an anti-racist toolkit about how you can look at disparities in your community to the 4 building blocks. So who in your community, in your practice, in your office is not accessing one or more of those building blocks at rates of, let's say, the white kids. Find out where those disparities are, and then this toolkit talks you through working with the community who's experiencing that disparity to problem solve and figure out policy and practice changes so that they too can increase their access to that building block to decrease long-term health disparities that we're seeing. And so our website is positiveexperience.org. And I think I would love to open it up for some conversation and some questions. I did see one come through the chat, so I'm just going to jump in right there if that's okay.
Sure. Welcome back, Dr. Goldfinger, too. So Amanda, go ahead. Let's start with that question in the chat.
Yeah, so our positive childhood experience is the same as protective factors. Yes, so we're not the first people who did this. Positive childhood experiences refer to specifically those 7 questions that were asked, which have a ton of overlap with protective factors. Strengthening families is doing this work. Help Me Grow is doing this work. And so when we talk about positive childhood experiences, our framework is one of many. And our goal is to really make sure that the pendulum starts to swing a little bit from strictly paying attention to those adverse childhood experiences to working with the families to promote and increase the positive as a way to take some next steps, to lean into action. Because I think what we're seeing is that as more and more providers are screening for ACEs, which is important work to do, let me be clear about that, that families walk away from that sometimes feeling a bit discouraged. You leave an appointment and you learn that you or your child has an ACE score, and you've also learned what that might mean for later health, and it's like a so what? So we want to give them a now what.
Great, thank you, Amanda. And we will share with all of our attendees a couple of now what one-pagers that Amanda and her team at Tufts have created, one for providers, that those who find they do have an ACE can and take to their providers, and also families, some of the things that families themselves can control. But Jonathan, I'd love to kind of kick it back to you. We're in the fireside chat conversation now, and we invite those of you who have questions for our presenters today to participate through the chat feature as well. But I wanted to kick it back to you, John, because I think some of this conversation about now what you sort of hinted at, you were not initially a big fan of screening for ACEs. I think really because of this sort of now what piece, and perhaps some other other things that you might be willing to share with the audience.
Sure. So, I would say largely due to my own trauma and ACEs and resilience, that positive and safe, stable relationships over time built in me, I'm a pragmatic possibilist. I'm pragmatic, and I'm a physician, and I have spent much of my career feeling squeezed by healthcare, whether it's my employer or insurance companies not paying enough for these clinically important evidence-based needs, to say, how was I going to fit into a 5-minute visit where I have to vaccinate? Now we all champion, right? I got to vaccinate. I got to talk about the kids' development. I got to screen for the kids' development. So this is not the only screening. I got to screen for the mother's mental health, which came first as a recommendation from the American Academy of Pediatrics. I've got to counsel them. I've got to make referrals. I've got to type a note. I've got to send a bill. I've got to see the next patient. I've got to call people back, etc., all in 5 minutes. And then someone came and said, hey, we should be opening up this can of worms of what happened to people in the past. So my knee-jerk response was, well, that's very nice, but this is not possible in that amount of time. And I'm not trained to address mental health or childhood trauma. We've come a long way in these things, but that wasn't there. And I will lose money. Pragmatically, I cannot afford my practice and pediatricians everywhere and internists and obstetricians to do this and lose money and therefore see less patients overall. So vaccinate less kids, address the developmental challenges that ACEs lead to in kids. So this was just a strictly pragmatic then what, and how does this actually all work? And what we found is we were able to research at the Center for Youth Wellness. Once I agreed, okay, I like a challenge, so I'll take this on with Nadine Burke-Harris. We found that the implementation of the ACEs screener could be done in different ways, could be done quickly, and could be done what we call de-identified, without opening up the bag of worms, just asking the family about the dose. And interestingly, we found if you just ask about the dose, the score, not exactly what happened, over time, you're also just as likely, if not more likely, through building trust, to get at what actually happened. So we addressed the timing issue. Then we did significant advocacy, as I know you all do, and we have to continue to do in this arena, to get the state of California to actually pay pediatricians and other primary care providers to do this. So we solved for the time, we solved for the money. And the last thing that's still, I would say, a holdout here this forward is the access to mental health care.
Yep, thanks for that, Dr. Goldfinger.
In America, right? Primary care, you can get primary care 100%, near 100% of the time. But mental health care, if that's the issue for the mother, that's the ACE, or even for the child who's traumatized, you have maybe a 40% chance of access if it's a substance need, maybe a 10% chance of access to care. So to me, that's the last holdout.
Then what? Yeah, that we need to solve for. Really great insight. And to that point, we're talking about lifting up California's model because it has been getting a lot of great attention for the reasons Dr. Goldfinger just shared, including the payment piece, which we all know is critically important, not just to put one more thing on a provider who's already overwhelmed on their plate. And this comes up, as we all know, in maternal mental health screening as well. Payment must come. But California has solved for the ACEs screening payment issue. There's also work happening in many states, including California, around reproductive psychiatry consultation. Again, sort of payment issues there for pediatricians and obstetricians to make sure their time is accounted for as well. But those solutions are being discussed. Just want to share that. And many of your states, I saw someone comment about how exciting this is to hear some of the content from a West Virginia perspective. So welcome, West Virginia. And I think other states may be in the same boat. We're so glad to share some of this content and to be here to support you as you do work around payment reform, et cetera. Dr. Goldfinger, one other question for you that's somewhat related is this whole issue of integration. You hit on it on one of your slides, but if you could wave your magic wand and do something to help with behavioral health, medical integration, what would that be?
I would ensure that every state enforced existing federal law to guarantee that no matter where it comes from, every form of mental health care is paid for equitably and in parity, meaning equally with how we pay for physical health care. You can't even integrate care. For example, I used to lead integrated care across the United States in federally qualified health centers, but in California and probably elsewhere, we have a law where if the mother comes in with a baby and they're on the menu, if you will, for lactation support, often billed to the mother's insurer, physical health issue, baby, check the bilirubin, weight check, etc., all related, and you identify a mental health issue in the mother at a federally qualified health center, you can't actually bill for both on the same day. So even if I had a social worker, or when I have had or led integration of social workers, mental health professionals, the current lack of equality and essentially justice and access to payment, fair and equal payment for mental health services compared to physical health services is the single biggest gap for the ability to integrate mental health care into primary care. And interestingly, for us at D.D. Hirsch, where our health system is based on the tenets of mental health, the opposite, for us to integrate physical health care. We integrate it, but how to get paid for all of this fairly and in parity that's what I would do. It's not sexy. It's not, give everyone a mental health professional. I care about the sustainability as much as I care about the magic wand, and that's how it would get done.
Yeah, no, it's spot on, and that's one leads to the other. This is foundational work. And just to elaborate on your point about parity, we hear about parity often, that there's these discrepancies in how mental health is treated, and you address one of them so beautifully. And the federal mental health parity laws right now largely address payment parity, so how much someone pays out of pocket. And what you're really talking about too, Jonathan, which we think is like phase 2 or 3 or 4 of federal mental health parity should absolutely be prioritized, is carve out, right? We have mental health carve outs and separate rules for mental health delivery systems that just shouldn't exist, right? We don't carve out the brain from the body. We don't carve out the heart from the body, excuse me. Why do we carve out the brain? It should be baked back into medical plans, payment plans, and not bifurcated, right? And treated separately in these different policies and different insurers and different health plans, and all of these things complicate delivery of care. Thank you so much for that important point, Dr. Goldfinger. I'd like to now just open it up through the chat, and we're going to turn it over to Amanda here in just a minute, but I want to hear from all of you about, many of you are mothers on the line. What kind of protective factors, positive factors as mothers would you like to see change from a policy perspective? And I'm going to give you a few examples to get your juices flowing, right? We heard that sort of practical support can be, like, lack of practical or social support can be a baby ace. When I hear that, something like paid family leave and being able to be at home and be paid to be at home from my job would be a policy change that we could work on effectuating passage of paid family leave, maybe affordable childcare. I don't want to limit it to those kinds of very obvious federal policy opportunities, but anything else, what would have helped you as a mother, or if you're a provider, what do you think would help the mothers that you serve, or expecting mothers that you serve? So we're going to see some of these roll in, and then we'll ask Amanda if she has thoughts, and of course, turn it back over to Dr. Goldfinger for his thoughts as these comments roll in. So the first one that came in, and please don't be shy. The first comment that I see that came in, is just addressing anxiety, not just depression. So the role of anxiety, anxious motherhood. That's a great point, kind of in the larger fields of maternal mental health. Most of the initial research was done on depression and not so much anxiety, but definitely been more recognition, including by the American College of Obstetrics and Gynecology, on the role anxiety can play both to lead to preterm birth and also in causing distress in the postpartum period. And it can be a precursor, as we know, to depression as well. So really great point. Prescriptions for healthy food. That's really interesting, a prescription. So not just coverage for like the WIC program, but like doctors saying eat healthy food. That's interesting. Okay, so OBGYN. So we're hearing from some folks in the maternal mental health field that let's like actually implement some of the recommendations from the American College of Obstetrics and Gynecology, which is, to John's point earlier, Dr. Goldfinger's point earlier, sort of this payment piece is lacking, the insurer piece and the Medicaid reimbursement piece around some of the ACOG recommendations for fourth trimester and even for screening for maternal mental health disorders. Great, so we can see some of these things coming in. So how do we empower women to understand self-care and give them the support that they need for self-care? Great. Well, I'm going to turn it over to you, Amanda. Any comments from you about low-hanging fruit around policy change? What can we do about this?
So I mentioned that I spent a decade in Berkeley, and I very much align with being a Berkeley mom. For whatever stereotype that brings up for you, I am it. So a low-hanging policy for me here is around funding postpartum doulas for moms. I know isolation was a big deal for me, and I had a pretty strong network around me, but you can feel very alone in that fourth trimester. So making sure that, going back to those 4 building blocks, that you are proactively funding relationship and safe, stable environments.
Great, thank you. And doulas, certified peer specialists, all of these types of community health workers reimbursing for those types of services. Dr. Goldfinger, what would you add? Low-hanging policy fruit, and we will reinforce the bills that you shared and opportunities for those who registered for this session to get engaged in advocacy around those bills. Anything else that you want to mention that maybe wasn't addressed in policy yet?
I would say we're nearing the point, I don't know how low hanging, but we're nearing the point where we begin to think of doulas and other navigators, care coordinators, and those services as critical. And my vision is one day everyone will have a care coordinator or a case manager, because our systems are so fragmented. We need that. So I would expand upon what Amanda said and ask for doulas, ask for CHWs, ask for home health nurses, ask for yada, yada, yada. If we actually paid for these people, the underlying theme here is people with the knowledge, often the lived experience, and they are the safe, stable, nurturing relationship. As medical doctors or even mental health professionals, we don't necessarily have the time, and we cost way more than people who can be that buffer of the ACE or the toxic stress. People can be that positive childhood experience in your life. They're not a family member, but often patients, mothers, and others refer to them as a member of their family. It feels that way because they call, they check in, they say, how are you feeling? Did you get your meds? Are you sticking to your treatment regimen or your plan? How's the baby, right? So these people operate like those safe, stable, nurturing relationship buffers. And it's time that America invested in all of them wholesale, rather than act like they're fringe professionals, right? They are the glue that ensures that people will access the care they need equitably, and we have to fund them. Oh, I forget lactation professionals. There's so many of these professionals who are underutilized. Often healthcare treats them as less than, which is, I call my provider colleagues to stop that and to learn about their professions and the evidence behind them, because they have significant evidence for impact, and to bring them into the care team. But then we need policy that says, if there's a person whose job it is to connect someone to a resource that's hard to get or has low access rates, we'll pay for it. If we did that, we'd really solve for a lot of this.
Amazing. That's a great place to end. Some real tangible solutions around basically peers and providers that support through the perinatal period, all of the challenging situations, delivery, lactation. providing reimbursement for those services is really great, tangible next step. We thank all of you who've joined us today. We will be sharing some opportunities for advocacy with all of you in a follow-up email along with the recording from today's session by Monday. So we thank our speakers today as well, Dr. Goldfinger and Amanda. Thank you so much for being with us. We will be following up with some more content around PACEs, ACEs, ABES, all of the above. Thank you so much for joining us today, everyone. Have a good remainder of the week. Thank you, Dr. Goldfinger.
Thank you. Thanks all.